Well, I can't begin to tell you what a pleasure it is to be invited back to the Brotherhood here. And of all those accolades, the one I'm the most proud of is the bottom one here, which is a graduate of the THI Fellowship in 1996. So I want to thank Zvonko and Stephanie and the crew for inviting me to come back and speak here at my alma mater. You know, you would think I'd be talking about endovascular, but, you know, this is a place where endo and coronary work and the innovations. I was downstairs in the innovation lab, just realizing how much is done here that really changes the world and changes patients' lives. And what I wanted to do is introduce you to some things that I think that will be intriguing to you, but also maybe a little bit scary. And Stephanie Coulter was asking me last night, so just give me the bottom line. Is it going to actually replace me or not? And I said, Steph, I don't know yet. No, honestly, I think that this is a topic that's obviously in the news and of interest to a lot of people. So let's get to it. So first of all, don't worry, Steph, AI is not going to take your job. It's just going to make it better. So the diagnosis and treatment of cardiovascular disease will and already is using multiple forms of AI. And I'm going to show you things that you probably are aware of that have AI technology, but have not really looked at and thought, okay, that's something that's changing the way I treat patients or diagnose patients. So how do we do it today? And how do you think we're going to do it in, say, 10, 15 years? Today, as you know, we see patients in the office, we examine them, we get the history, we get the physical, and then we use this thing called the stethoscope, some of you may be familiar with. But for the most part, what's happening is that there is a little bit of changing of the way that we evaluate patients remotely, and there's an untethering of that assessment. And we know that patients are asking for that. If you look at what happened through COVID, we started with televisits, and even through the time when we couldn't see patients physically, they were not really that quick to come back into the office, all of them. So we probably, just like many of your practices, 25, 30% of the patients we see still come from far away, don't have access to see us on a regular basis, and interim visits will still happen through telemedicine. And we know that many of them, over 50%, want in-person visits for the first time, but if it's going over testing, et cetera. So this is the transition of where these type of technologies will come. When we think about that, we'll need devices that'll be able to give us the same information remotely as they do in person. We're going to talk about those type of devices, remote EKGs that are done with a little credit card device I'll introduce you to, retinal scanners that'll tell us whether a patient has vascular or cardiovascular disease, and then simple phonographic testing like this CAD score device I'm going to introduce you to. And that data will then be able to be transmitted through the cloud to just about anywhere. We were testing a device a week ago called a Gabongo, which is basically, it interacts with a monitor, a Merit monitor, which we have in our cath labs. And we were looking at the vital signs through the graphic images that come up on the monitor, and those are turned into digital formulations, and then that is transferred to India, and we're able to see those back at the exact same time. So some of this I'll introduce you to. Not only that, probably the one place where AI and things that are in that nature will probably make the biggest impact is imaging. But imaging not only for the assessment of cardiovascular disease, but also for the assessment of the underlying plaque, the plaque morphology, and understanding it a little bit more closely. I know for decades we've been trying to figure out which of these plaques is vulnerable, which of these plaques is going to be problematic, and using some of these technologies with thousands and thousands of data points was going to help us figure that out. And then when we have that information, we're going to want to then put that information into a repository or databases that tell us what should you do with it. And we're going to use things that are similar to ChatGPT or other generative AI models that'll say, listen, here's what the algorithms say you should do. Here's what the guidelines say you should do. And this class of patients is going to be treated this way. So more uniformity in the way we treat patients. So as we move from fee for service to fee for value, there will be an equalization and a normalization about the way we take care of patients. And I think that that's slowly but surely evolving. We've been talking about that transition for probably about 2 decades. In the future, in addition to the evaluation and testing that we're going to get on the front end, patients will be followed up as on the back end with other types of devices that are also remotely monitored, and it'll be done through multiple testing opportunities usually through use cases of whatever their diagnosis is. So if you have heart failure or if you have coronary disease or vascular disease, there will be different IoT type devices. After you finish heart surgery or vascular surgery, you might be doing your afterwards, your physical therapy and rehab through a virtual system, and that'll be part of your overall recovery. And then if you have conditions that are symptomatic, shortness of breath, chest pain, or pressure, whatever the symptoms might be, you might talk into your Alexa or your Google, and that will then relay information back to your physician. And I'm going to show you some research that's going on to use some of these devices. So that's the past, and this is the future. People always ask, so what are the actual definitions of some of the things that AI has to do? So let's level set some of the definitions. So ML or machine learning is something that we frequently hear. We read about it in U.S. News and World Report. We read about it in the Times. We read it and we're like, what exactly is this idea? Where it really impacts us is that all of those images and all of that data and all of those have patterns. And those patterns ultimately allow us to make inferences. But we think we know what those inferences are because we know what the important data points are. But the more data points you have, thousands and millions of data points, start to give you a sense that maybe there's some parts of the data that are more revealing than what you expect. So for instance, we'll get into whether there are earlier signs of, say, for instance, heart failure, coronary disease, or other correlations that occur from testing that we didn't think would be able to diagnose those. NLP, or natural language processing, emphasizes in a computer's ability to understand the human language, but also if you look in your electronic health record, whether you're an Epic or Cerner or ECW or whatever it is, you may have your primary health record in one queryable pattern, but there's all kinds of APIs and other types of data that are in that record, and you can't query them on a real-time basis. So natural language processing can take that and create what we would call a unified health record. And in the future, you will be looking at unified health records. So where all of this information comes into one place and it gets scrubbed through a process to be able to then tell you how you should be assessing the patient and what you might be doing. In addition, there are multiple layers that that data will go through in the form of artificial neural networks. These are networks of biologic and nervous system computational algorithms that allow you to take lots of information and then discern what's important, what's not important, and then start making predictive analysis. And I think that those are the things that are going to change. Computer vision is the one that's the easiest for people to understand, and that's essentially taking the analysis of an image and saying, what's missing here? Like that old Saturday morning cartoon, tell me the difference between these two pictures, and you can start to see, hey, wait a minute, there's a mass here that shouldn't be here. Maybe that's something we should be figuring out. And then remote devices, wearable devices, and patient monitoring will continue to expand in ways that you may not be familiar with right now. There are point-of-care tests right now using just simple bracelets that look at troponin levels, that look at other laboratory levels, that look at patients' changes in their EKG compared to baselines, which I'm going to introduce you to. So what we did for a long time is what we called supervised learning. In other words, we thought we knew what the parameters were. So if you have heart failure, your weight went up and you said, okay, this patient's getting worse. And then there are unsupervised learnings, which is all this data and information is starting to tell us little subtleties that are internal to that data that you may not have identified as things that change along the patient's journey. So the four primary uses of AI, and I just listed some companies that we're already working with and you've probably seen that do these four things. And think about AI as in four buckets: large amounts of data, recognizing patterns, and predicting outcomes. That is a large part of what AI is. It's taking information that every one of us generate, patients generate, thousands of data points, and starting to see patterns that we may not see as individuals. In addition to that, there's those pieces of information that are related to the imaging, whether it's echo, nuclear, vascular, other forms of testing, and those have subtle information in them. And we know that there are individuals that have different skill sets in reading those. What we want to do is sort of normalize the ability to look at something and to be able to operationalize what you do with it, and even at the bedside. As machine learning, artificial neural networks, and computer vision all associate this disparate data, you're going to be able to take a large amount of information and to be able to distill it into useful packets. And then ultimately, you'll upload this into a system that will be at the same time evaluating that and identifying whether or not the patients are on guideline-directed medical therapy, or whether there's something that you're missing in the diagnosis or the evaluation and treatment. And there's a ton of these groups out there that are starting to do this, and we're testing some of this as well. So you can start to see that this is not going to really replace anybody, but what it's going to do is going to make every one of us a better physician in the end. The current focus, this is an article done by one of our colleagues in New York, Dr. Ilias, who looked at what is going on right now with EKGs, echocardiograms, testing that we already do that has AI uses. So you can imagine if you were to use the kinds of devices we use right now, like EKGs, what information can you glean from an EKG? I mean, I think that first of all, you have to quit looking at the top of the EKG bar, because that's actually not AI. That's a computer-generated diagnosis, which is probably wrong most of the time. But if you take each of these four things and then you add the data that comes from these systems, from EKGs and others, you can glean information that's way beyond what we can look at previously. So let's just look at electrocardiograms and wearables. This is a device. I don't know if anyone has had the opportunity to take a look at this or seen. Has anyone seen this HeartBeam EKG machine? So this is a vector EKG that essentially is like a credit card. You put it on the chest, and it's at the FDA right now for approval. And it's an interesting device because human readings can identify changes and subtle changes in EKG and sensitivity and ST changes about 70–75% of the time. This gives you a baseline, and then if a patient that has known coronary disease or maybe had a previous MI calls your office and has one of these devices, there's a chance that up to 90% that you're going to see these subtle EKG changes. And the examples are going to look like this. You know, we can look at an EKG in isolation, and it looks like the baseline that you see here. But if we didn't have the old one and we don't have the new one superimposed on each other, we may not know that there's a subtle change or a difference. So you're going to start to see differences in those patients in those EKGs. And from EKGs, we can start to see things like structural heart disease diagnosis and other things which you would not have thought would be able to be diagnosed from these simple tests that we are doing right now. Echocardiograms are no exception. There's obviously the ability to read echocardiograms is a subtle skill that has a variation. And overall, I think that one of the ideas about using AI in echocardiography is ultimately to get diagnoses sooner and also to be able to be more accurate with those diagnoses. So EchoGo technology, which you're probably familiar with, is an idea that you can actually diagnose heart failure with preserved ejection fraction and heart failure without with reduced ejection fraction in ways that are better than the readers. So there's readers of all kinds, and what we know is that cardiologists' agreement on left ventricular ejection fraction and other forms are better with AI. So if something is pointing out to you that there's an issue or an abnormality, and then you can verify it visually, you're going to enhance your ability to know what's going on with those patients and those echocardiograms. No different than the MRI. But those of you that are familiar with myocardial solutions, this is a strain scale that looks at the MRI of the cardiac gated studies and then assesses whether or not there is a difference in contraction at a very high level of those myocytes. So you can imagine someone that's undergoing chemotherapy, and cardio-oncologists are interested in this type of evaluation. We were using this at our Baylor facility, an MRI machine that evaluates patients prior to them getting chemotherapy. And then you can very subtly identify myocyte strain, which is really imperceptible to the visual eye. You won't see it on echo, you won't see it on other things. And this strain score and this scale starts to identify those that are going to do poorly with chemotherapeutic drugs. And as you know, checkpoint inhibitors and other things like that, it's late when their ejection fraction starts to drop. So if you can pick these patients up and either change their dosing or change their therapy, you're going to have a much better chance of making those patients better or reducing their risk of going on to severe heart failure. So EKGs, echocardiograms, MRI, they're already using forms of AI and technologies. I don't know if you guys are using CathWorks in your lab, but it is a technology that we use on a regular basis. And what is it? So you know about heart flow, and we'll talk about that in a few minutes, but this is a system that you can do an angiogram on a patient, and then you put it through this resistance AI program right at the bedside. And instead of putting FFR or IFR wires down every single vessel, you can take 3 images of a vessel, get this resistive index, and it gives you an FFR on the spot. We use this thing on a regular basis. And the beauty of it is it's AI-generated information that when we test it invasively, it also gives us that same sense of whether or not a lesion needs to be treated or not. So the appropriate use criteria gets automated pretty quickly. You have multi-vessel disease, you can decide, I don't need to treat the left main, but I can treat this right coronary and leave that left main alone, or the otherwise. So I think that these are all technologies that take what we currently do, whether it's echo, EKG, other forms of imaging, and either coronary angiography, and it gives us a sense of what we might want to do interventionally. And then ultimately the outcomes of these patients will be incorporated into these systems. And then you can then look at when we identify those patients that don't need something done, how do they do? So you can start to see AI is all around us and we keep using it for different things. This started way before the imaging that we have for echo and EKG, et cetera. If you can imagine on this left side, what you're doing, this is the simplistic way of looking at it. First, you just get an image acquisition. This is a chest x-ray. You want to identify whether the patients have left ventricular hypertrophy or they have heart failure. So you get it. You guys remember chest x-rays, right? So we still get some of those. So you get a chest x-ray and you assess the patient, but then that same chest x-ray is digitized and put through this neural network. And so the second phase of this is that data becomes equalized and an artificial neural network filter starts to look at that and millions of other x-rays and starts telling you whether or not this patient actually has these certain conditions, things that you may never have picked up on in the past. So the area under the curve for the composite of this AI-based program is, as you can tell, better than the readers. So you can imagine that once you put it through this program, you can then identify whether patients have predictive analysis of certain conditions. Do you have left ventricular hypertrophy? Do you have heart failure? Do you have other things? Image performance and optimization is then performed, and this AI outperforms individual radiologists. So you can see that we're starting to create a collaborative technology compendium of things that we can then use to make us better physicians. And the question is, what do we do with the data that becomes identified here? And that's the part I'm going to get to next, is that then you basically use that in these formats where you can identify, are we using, best medical practice and are we following guidelines, et cetera. There's some things you may not have seen or may not have been exposed to yet, some diagnostics for coronary and cardiac disease. So retina scans have been around for a while, but now there's some predictive nature to some retina scans looking at the retina and cardiovascular disease. You can actually take a patient, identify their age, gender, whether they have coronary disease, and actually whether they have diabetes, et cetera, based on millions of retina scans. And there's several companies that are doing this. AI Nexus is a facial recognition company. And essentially, it takes multiple parameters from the video stream of essentially from your smartphone. And that AI goes through an algorithm, creates a PPG signal, which then digitizes whether or not you have a likelihood of having certain conditions, cardiovascular conditions particularly, and it's coupled to some devices that give you vital signs. So the combination of the facial recognition and the vital signs then start to make predictive analysis of what's going on with that patient simply by looking at their face. I mean, probably our mothers taught us this when they looked at it and said, boy, you don't look so good today. Well, this is just an enhancement of that assessment for sure. But I think that it's just an identification of ways that you can actually see where these technologies might be able to take us. Not only will visual representation give us information, but sound recognition, and there's multiple ways of doing that. You can imagine if you are sick, you sound different. In addition to that, there are ways in which Google Translation of AI for millions and millions of sounds starts to make diagnoses as well. So listening to thousands of patients with lung disease or obstructive lung disease, coronary disease, or others, goes into your algorithm, comes out on your Google or your Alexa. And there are other systems that are already in place right now. This one in the middle is basically a electronic stethoscope, which costs about a few bucks to make. It's not very expensive. It attaches to a cell phone, and that cell phone has a program that has the ability to identify murmurs. A trial was done. There's a company called Medical Heart. They did a trial with Edwards Life Sciences for identifying folks with valvular heart disease in Europe and in the UK. And they identified patients very, very well by using these algorithms that are now connected to AI and say, yep, what you're listening to is aortic stenosis, and this is the severity, et cetera. So you can imagine the combination of the visual inputs along with the sound inputs and some of the other things will give us these diagnoses much more clearly. This is one device that I think maybe you may have seen. I'm not sure. It is a Swedish company. Basically, it's a phonocardiographic device. You put it on the chest just like you would a patch. And essentially what it does, it's listening for heart sounds. But it's not listening for murmurs. It's listening for coronary stenosis. I'm like, how in the world can you listen for coronary stenosis? Well, I'll tell you a story. When I was trying to decide between Mass General and UCSF, I was a Baylor student, and I went for 1 month at UCSF and 1 month at Mass General. And at UCSF, I made rounds with cardiologists you may have been familiar with, Kanu Chatterjee. I made rounds with Dr. Chatterjee, and he would go up to the patient's bedside, and he would listen to the patient's heart. And then he would ask the resident what he thought, and the resident would say, oh, I think it's a systolic murmur, such and such. And then he'd go to the next level. And he was such a kind man, he'd say, no, I'm sorry, I think the murmur's changed. So his ability to listen, but one of the things he would say is, I think this patient has a 70% LAD. I'm like, how in the world? Well, this is the device. I would call it the Kanu Chatterjee device. And what it does is it gives you not only let me go back one. I'll just tell you. So it gives you an output of a score. That score is 20 or less or 20 or more. If it's 20 or less, the patient has a 96% negative predictive value of coronary disease. Been validated on over 30,000 patients. If it's 20 or more, there's a chance of coronary disease. You can do further testing. So you imagine as you go from fee for service to fee for value, if you're really trying to screen a patient population, can you figure that out by using simple tests like this, where, you know, we have plenty of patients who are the worried well. They're getting calcium scores, they're getting CT angiography, they're getting other expensive tests, and maybe those tests could be obviated, at least in a bifurcation way like this. So the key point is that AI for diagnostic imaging really does increase the accuracy and, more importantly, reduces the variability. So if I have Stephanie Coulter read my echo versus if I read it myself, I know that she's going to read it better than I am. But on the other hand, if Stephanie has diagnostic accuracy with AI, she's going to read even better than she does right now. So I think that this is one of those things that's going to make a big difference. On top of that, once these images get processed, there's other things that we can start looking at, including the way that those images might act physiologically. So we'd always thought of imaging as a anatomic input, but now we're looking at it both anatomically and physically. We're familiar with heart flow and Clearly, both of which we use in our practice. It's an interesting addition to our use. This is a computational flow dynamics, basically taking a CT scan, adding an AI algorithm over it, and identifying patients with these colored graphs of their coronary disease, and red is bad and blue is good. So that makes it simple for us interventional cardiologists that are mostly in the plumbing space. But the point is that it really also helps you understand how and if to treat these patients, and also maybe where to treat these patients. So if we're making a transition into less and less, hospital-based procedures and maybe more and more into outpatient-based procedures, or even, ambulatory care locations, you can really plan interventions, case planning, and site of service by having this kind of information. I'll give you an example from just a few weeks ago in our practice. And I hate to say I was a smart one to figure this one out, but the AI told me what to do with this patient. It's an 83-year-old patient. I've been taking care of him for a while. I put a carotid stent in him last year and an aneurysm stent graft in 2021. Really nice guy. Keeps coming back complaining shortness of breath. And we knew he had a right coronary occlusion, and this was a chronic problem. And nuclear stress test, he was going to have a repeat follow-up in 2020, and that got canceled during COVID. And his ejection fraction was normal. So, of course, I sent him to the pulmonologist. If you're short of breath and it's not something I can do, I send you to the pulmonologist. Pulmonologist says, guys, our lungs are fine. I said, okay, well, maybe I'm missing something. So let's do a nuclear scan. So this is a SPECT scan. You can see there's an inferior defect here. So, okay, well, guess what? He's got a chronic right coronary occlusion. Doesn't really look terribly ischemic. So at this point, basically look at these images. They don't look that bad, right? Would anybody go any further? The guy's still short of breath. I still don't know what's going on. So the heart flow analysis is done. We have a 560 slice CT scanner in our office. And so we did a CT scan, and much to my surprise, this is what his LAD looked like. This is full of calcium and full of plaque. And so we knew his right was occluded. This LAD was pretty severely diseased. Honestly, I didn't see a lot of ischemia on the nuclear scan. We did an angiogram. Of course, the right's occluded, which you would expect. And you see some collaterals to what appears to be septal perforators. And then look at this heavily calcified LAD. So wired this thing, not a single balloon would pass, as you can imagine. So I'm pushing these, tiny balloons, 2 millimeter, 1 millimeter balloons. Nothing goes through. So what did I learn from the Heart Institute? How to use a rotablator. So we did the rotablator and placed the stent here. And I see the guy in the office yesterday and his symptoms are gone. So we're a lot of uses in the coronary space. It really does well. And we've also extended this into the vascular space. So Dr. Frazier taught me everything I know about the vascular space, and I thought that AI wouldn't help me because I already learned it all here. But no, there's a few things that I think there's still left to be learned. And part of it is just the diagnosis and assessment of patients with vascular disease, just like coronary disease, has a lot of variability in the assessment. And the vascular imaging, CTs and ultrasounds, again, can be read very differently. How much variability? It can be as much as 15% can be missed. So you ask yourself, when you have a scan like this and one reads that scan, is the aneurysm or the carotid, what more can we learn about these scans using AI? Well, it turns out there's probably a lot. What we know about coronary disease has been done with research and testing with really millions of patients. With vascular disease, as you see, a lot of the data is on much fewer, many fewer patients. And so the question is that, are there tools that help us identify using AI and predictive analysis as to how patients with vascular disease are going to do? And it turns out that there are. So one thing you can do, similar to the heart flow analysis for coronary disease, is that you can actually look at these studies, pick them up faster. So this is clinician diagnostic errors for AI performance in vascular tests. So this is how often there was a misdiagnosis or a missed diagnosis. AI is in green, which is lower, and then clinicians are in blue, which are higher. So the point is that we look at the exact same studies as the AI analysis does, but we miss about 15% of those based on the fact that the algorithms can pick up patterns much more quickly than we can. So just like back to the assessment of those carotid lesions, what is it about those that you might learn more about if you picked it up? Aneurysms as well in testing, and I know that Svanko and the team here have done a lot of case planning, et cetera, using 3D analysis, and we're also doing similar things for fenestrated grafts and things like that. And I think that these are all AI-based technologies, which you bring the CT into the cardiac cath lab or the operating room. One of the things that's interesting is that even though that we have predictive analysis, which are relatively weak when it comes to things like aneurysm growth, we have that rule of, okay, 5 centimeters for an abdominal aortic aneurysm is when we need to start being concerned, but then there's patients that rupture at lower. The initial diameter of the aneurysm is well established, but there are so many pieces that are not identified in that simple assessment by CT or ultrasound, and that is the growth rate of an aneurysm, the wall stress, and you add AI to that, what you start to realize is that the predicted diameter of an aneurysm can actually be assessed very accurately by adding multiple other parameters. So before we just used what we called the supervised learning parameters, right? Which is essentially the size of the aneurysm and the growth rate. Greater than 0.5 centimeter over 6 months, it may have a potential for a rupture. But if you look at the red dots and you look at how well they overlap the actual size of the aneurysms over on that right side of the graph, they're almost completely overlap. And that's by adding more information through AI algorithms. So you say, I'm not just going to follow these patients by doing an ultrasound every 6 months or a CT every other year. I'm going to use these predictive analyses. And with that, I'm going to be able to tell the ones that are really going to rupture or have a potential for rupturing, or the ones that we just need to do assessment and follow up instead of doing something invasive for them. That also exists. We talked about carotid disease and aneurysm disease, but for peripheral arterial disease. So if you look at this, this is a study done at Mayo taking, again, a unified health record. That's the middle portion here, and assessing for disease, drugs, procedures, things that are in the record already that we could identify as abnormal. And then look at how the area under the curve for using these technologies not only predicts whether the patients have peripheral arterial disease, but what their major adverse events are based on the technology or based on the information that's already in the chart. So you talk about going from a fee-for-service to fee-for-value world. You not only know who has the disease, but you also know who's going to have problems with the disease, whether it's carotid, aneurysmal disease, or peripheral arterial disease. So the whole spectrum of coronary to peripheral is really enhanced by the utility of having AI-based technologies. We have used this CarePix technology here in the middle, which is to follow wounds, and we can now speak language patients that have arterial disease with each other and how quickly these wounds improve. One of the things I know doing a lot of lower extremity vascular work is that these patients get lost to follow-up very quickly. They might see a podiatrist, they might not. They go to wound care for a while. They sometimes get lost. And so if we had a way of longitudinally assessing this, and these are AI-based programs that allow you then to follow the patient, and everybody has access to the information, and then it'll recommend whether there are graft analysis, anything that you want to do to that wound. And we've started using some of these in our evaluation and assessment. That are AI based. Those same things can help with prediction. So this is a plaque analysis for carotid disease using Elucid. So right now you know of HeartFlow and Clearly. Recently, about a month ago, FDA approval for a third plaque analysis program was achieved in October. And Elucid basically allows plaque analysis and has shown predictive outcomes for different types of carotid disease. So I want to know if the patient can basically be followed and watched that has a moderate to significant carotid lesion. But if I know predictively that the stroke risk is reduced, I don't need to put in a carotid stent or send for carotid endarterectomy if we know what the outcomes of those patients are on a predictive nature. And I think that those are the things that we will be using for not only for diagnosis, but for treatment and prediction. And this starts to identify the type of plaque, but not just the severity of plaque. So you're getting anatomy, physiology, and function from these tests. So you're just getting a little bit more detail into what's happening. Not only does that happen for the pulmonary embolus, but it can happen for other vascular conditions. So AI algorithms that look at CT scans for carotid disease can also look at it for pulmonary embolus disease. And you can then find a way of communicating this with the same language to other clinicians and to other caretakers of those patients, and you can quickly mobilize the workflows and accelerate how these patients are taken care of. So these are different types of programs that we're using on a regular basis in different places around the country that really do improve, I would say, not only the quality of care, but the uniformity of care. People are taking care of patients the same using guidelines and using the technologies that we have in our workflow. And I already mentioned the assessment of pulmonary embolus care. We have an app on your phone. It goes off when a patient has a CT scan that shows a pulmonary embolus or a likelihood of pulmonary embolus. It starts to tell you the ratio of the RV/LV, and you can then start to determine whether this patient needs to have, thrombolytic therapy or urgent referral to a tertiary lab. Last night we were talking about the access to care problem that exists. There's less than 40% of people actually have access to folks like you. And I think that if you can take the diagnosis from the more rural areas and then quickly mobilize teams to be able to treat coronary and peripheral disease, you're probably going to improve outcomes on a strong basis. But what do you do when you have all that information, and where do you then start to get generative diagnosis put into recommendations? So that's where generative AI, many of you probably have used Chat GPT 4 or 3.5. And so you can ask it clinical questions and get lots of information. So this is a study that was done looking at 4 different domains of vascular surgery, including aneurysms and carotid disease, taking into account the guidelines. And you can see that Chat GPT for the predictive performance of each iteration is better and better each time, meaning that when you have those pieces of information at your disposal, you can then run them through algorithms like this and be told, hey, this is a patient that has this condition and this is the treatment options. There are limitations to this. Obviously, sometimes it makes up data called hallucinations, and sometimes there's questions and concerns about data privacy. But ultimately, this is one way in which to take this tremendous amount of information and to be able to distill it into useful parts. So in the future, we'll probably just have the Alexa listening in the background while we're talking to the patient, and that'll be our second opinion, and say, hey, so Alexa, what do you reckon this guy's got here? And obviously, if we get too worried about artificial intelligence, we can just talk to our Google Dot, and they'll probably help us through that problem as well. There are challenges and limitations of all of these things. They include the following that you can see, not the least of which is privacy and security. And I think that one of the biggest challenges we have at Baylor and other places is implementing this stuff, because our IT departments are harder to get into and to get through than really any of our clinical departments. And I think that the advantages are there. We know that it improves diagnosis, assessment, et cetera, but data privacy, accountability, transparency, these are all real issues, and they need to be worked out before. But we also know that the role of human judgment can't be overstated. It is such an important part. But if you start asking questions in a Chat GPT and ask empathetic questions, you start getting, interestingly, empathetic answers. So that part that we thought was, hey, you'll never get empathy out of a computer, unfortunately, you'll get some. It may not be totally accurate, but it's funny. You should try this exercise at some point, and I'll show you some examples on the side here. So what is the future? Svanko and I were talking about training, and I know you guys were interviewing today for your fellowship, and ultimately your fellowship will be not only what you're doing right now, but it'll have all these other tools, which will include remote surgery, the assessment and tools for training maybe even more people in more remote locations, and using VR and other training devices that'll give you the opportunity to teach even more people so that access to care becomes even better. And for the last thing here is, what's the future? We know that artificial intelligence is kind of what we talked about today, but all these omics, whether it's proteomics or metabolomics, microomics, all of these are part of what is going to change our healthcare assessment. So if you think of the patient at the center of this, you've got the health system data, which we talked about. That leads to data which gets generated from their wearable devices. Ultimately, that changes based on their other sort of family history and omic data. And then using that, we can then identify sort of classes of patients with certain conditions that we may want to treat completely differently than someone that has the exact same diagnosis, but these multiple other underlying conditions. And a lot of this work is being done in precision medicine, which I think we will be impacted by here in the next decade. So in conclusion, AI-powered diagnostic tools, they are unfortunately outperforming in various areas, but they're really enhancing our ability not to miss things. AI does improve patient outcomes and reduces diagnostic variability. So as we move from fee-for-service to fee-for-value, maybe this is something we want to continue to embrace. We should embrace this because rather than replacing us, it's going to probably automate some of the things that are taking time from us being with patients. And human oversight is always going to be an important part of this, and it'll solve our most interesting problems. So for now, it feels like AI is maybe being forced down our throats. It says open wide and say AI, but ultimately, you better watch out because AI may do this. As you were Googling something like chapped lips, there's a chance you have this, and your coworkers, I've told them all the news. So data privacy is going to be an important part of making sure that we don't do this. Thank you very much for your attention. It was my honor to be here again.